Welcome to EM Pulse, bringing research and expert opinion to the bedside.
We're your hosts, Sarah Medeiros
and Julia Magana. Welcome back to EM Pulse. Guys, I am excited to co-host this special episode with my colleague, Dr. Neelou Weeker. Welcome back, Neelou.
Thank you so much for having me. I'm so excited to be back.
So today we're going to talk about something we don't always openly discuss in emergency medicine. That is the topic of teamwork when the outcome isn't good. What does that look like? Neelou, can you frame why this topic matters?
Absolutely. When we talk about TeamSTEPPS, we often connect good teamwork with good outcomes. But in emergency medicine, there are times when we do everything right and the patient still doesn't survive.
Yeah, I recently have had a couple examples of just that scenario.
It's tough. In those moments, strong communication, clear leadership, and role clarity still matter. They shape how the team functions in real time, how families experience the care we provide, and how we process the case afterward. To explore this a little more, we're joined today by Leigh Clary, our TeamSTEPPS lead and our wonderful ED nurse here at UC Davis. To review, TeamSTEPPS is focused on enhancing performance and patient care. She's done multiple recordings with us, and most recently on closed-loop communication and situational awareness.
Leigh, I know I've had some tough cases recently, but you had one too. Can you share your story?
Yeah, we had a patient recently who had a really prolonged resuscitation. And during the course of it, we did get pulses back. I feel like we were working as a very coordinated team. We were putting a lot of effort into helping this patient. And even though we got pulses back, we had to continue resuscitating for quite some time afterward. And then ultimately we realized that this patient was not going to survive. There were a lot of complications, and we had to switch course. We talked to the family, and the decision was made to withdraw care. So after putting a lot of heart and soul into this patient, we had to flip it around and make the decision to withdraw care, which was really hard for everyone. I know that it was hard for staff. The attending physician told me about how hard it was for him. He just doesn't like doing that. It just feels wrong to him in some way. And I did talk to him quite a bit afterwards, and he, even a couple of weeks afterwards, and he talked about how he had replayed the case in his mind over and over again and, confirmed with himself that he had done everything right, but it was still just really hard.
Yeah, those would've, could've, should'ves are really tough.
Yeah, Julia, those resuscitations are always really tough. Leigh, what made this resuscitation particularly challenging?
Well, I think for one thing, it was a long resuscitation. The family was invited back pretty quickly, and that's not part of what made it difficult, except in that it made it more emotional. Yeah, I think that we were all really hopeful when we got the pulses back, but then seeing the patient continue to decompensate after that was just really hard for everyone. And then having to explain to the family that despite our having gotten pulses back, that the likelihood of survival was very, very low. It was just emotional, and it was a bit of a roller coaster, I guess.
I think anybody that comes in talking and then dies during your emergency department stay is a really tough resuscitation. That's a challenging emotional burden to bear.
Yeah, the attending physician said exactly that to me about how difficult that was for him.
I mean, like you said, Julia, the emergency department, this stuff happens. And Leigh, I know you mentioned how the scenario was really challenging. Is there anything that made it easier?
Well, at the end of the event, we planned to do a debrief, and within an hour or two, we were able to get together and talk about the event. And so I think just that alone is always going to be helpful. And in the course of that debrief, we were able to feel pretty certain that we had done a really good job. Our teamwork had been coordinated. We had worked very well together. We didn't really miss anything. So at least we didn't have to carry that regret that this was potentially our fault or that we could have done something differently.
We've been doing debriefs at UC Davis for, I don't know, a long time. Leigh, what does an actual debrief after a resuscitation or after a death look like?
Well, we have debriefs that are led by our peer support team. So at any point, any staff member can ask for a debrief. And our charge nurse is going to prioritize making that happen. So in the debriefs, one of our peer support members will lead the debrief, and they have a format for doing this. So we go to a quiet or isolated place, and we just talk about what went well, what could have gone better. We have the opportunity to ask questions and have them answered. But there's also a component of emotional support to the debriefs as well. And in these debriefs, one important aspect of them is that they are confidential and they feel very safe. So one of the first things that happens in a debrief is we say the purpose of debriefing is for education, quality improvement, and emotional processing. It is not a blaming session and it is non-punitive. Anything said in the debriefing is confidential. So that's how our debriefs start.
Who leads the debrief?
One of our debrief champions ideally leads the debrief. If one of them is not available, sometimes someone who feels comfortable doing it, if they were part of the event, they may lead it.
And who attends it?
Everyone who wants to attend who was affected in any way. We make it a priority. Our charge nurses will shuffle staff around, do whatever they need to do to make it happen. I can say that there was one time, and this also was pretty recently, where there was a very emotional, especially for me, event where a patient, they didn't die in our department, but it was clear that they were not going to survive to leave the hospital. But after our resuscitation in the ER, I did not call for a debrief because we were so very, very busy that day. And I, to this moment, regret that because I had a hard time. The way I would say it, I had a hard time putting my feet back on the ground after that resuscitation. And I wish so much that we had had a debrief for it.
Yeah, I think that brings up a good point. Why do we do these debriefs? Like, how does it help team members carry the weight of what's just happened in the emergency department?
Well, for one thing, it gives us a moment to stop, take a deep breath, and reflect. And I think that's actually really important when you've been part of a really chaotic situation, is to be able to stop for a few moments. It lets us reflect on what we did well, so that kind of reinforces those things and can help us feel good about what we did. If things didn't go well, at least we're able to identify those so that we can look for solutions and prevent them from happening in the future. And just getting together with your colleagues helps you recognize that we're all going through this together, which can be comforting.
Yeah, I really appreciate debriefs. I think that act grounds us in our humanity. And what I mean by that is we often have to go from the death of a child or a loved one, somebody who's been a part of our society, and then move on and see, for me, a kiddo with a runny nose or a teenager with a twisted ankle. And sometimes you almost feel like a robot or an automaton in the middle of that act of like code switching so quickly back and forth. And that debrief moment reminds me who I am, my role, and the role of that patient in our society. And I can't carry every child that I have declared dead with me on my back and still function as a functioning, emotionally healthy person. But what I do is use that moment as a moment to remind me that I did the best that I could, or to learn from that moment. And I carry that moment of learning forward as a fence post for that individual who died or for that serious moment that's there. So my career has many fence posts of people that I have learned from, and I hold on to that piece instead of the horror of the other piece.
Yeah, I ran across information about a program that they tried at the University of Missouri where they had a team to respond to healthcare members after events like this to help give them support after events with bad outcomes. And they asked the people participating, what does general support infrastructure look like? What's the most important thing? And the most important thing to them was provide a brief respite or break from the clinical area to allow clinician to regroup, collect thoughts, and compose self. And I don't think that is recognized as the main function of a debrief, but we recognize it as such, and I think it is actually really helpful.
Yeah. I mean, when you just say it like that, I'm like, I can't physically leave the emergency department. Like, I can't go out and get a breath of fresh air. I can't go to the cafeteria and get a drink right afterwards because everything else has built up so much. So physically leaving is challenging for me. But I do think that structured debrief, and you're right, it is kind of out of the clinical context, like it's in a different space, in the doc box sometimes, or I think most of mine are in the doc box or in a room that is set aside for that. So you're right. It is kind of that implementation of that. I like that. Leigh, you mentioned that this attending brought it up with you a few weeks later. Obviously, that attending was carrying it. What are some things that you have seen other attendings, nurse leaders, other providers do that model healthy processing of these difficult outcomes?
I think it's helpful to others when you can show your vulnerability, allow people to see that these things do affect you. We're not robots. We're not able to just necessarily pick up and walk right on to the next patient like nothing happened. So I think creating a culture where it's okay to be vulnerable is important.
What about you, Neelou? What have you seen?
I think exactly what Leigh said. I want to be someone approachable that people can come to after any resuscitation and share their experiences without judgment. And for me, something in my practice that I learned in residency is when there's a difficult case, I try to always have a debriefing session to make sure that everyone feels like they were able to get all their thoughts and concerns out in this space.
I think those are good tips. And I love the practice we have at UC Davis of doing a formal debrief, of having these champions and having a framework. And also, nobody said it, but they often bring chocolate with them to the debriefs, which I have enjoyed over the years. There's like that all the senses are engaged in a reset at that moment in time. And if you are not doing this at your institution, I encourage you to explore this practice. It's not just a TeamSTEPPS thing, although it is an important part of that. It is a really helpful team building, humanity building tool that really does not take that much time or resources to do it. Feels like it at the moment, but in the grand scheme of things, it's very small as far as an investment.
And big emphasis, it'll boost your team morale. And I think in the emergency department, that'll be really helpful for team dynamics.
Thank you, Neelou, for bringing up this topic. Thank you, Leigh, for your advice on this topic. Thank you to our department for integrating debriefs into our difficult cases. And thank you to OM Productions for debriefing with us. Until next time, stay curious, stay inspired, and stay tuned.
The opinions expressed on this podcast are those of the hosts or guests and do not necessarily reflect the views of UC Davis Department of Emergency Medicine, UC Davis Health, or their parent organizations.